and introduce topics in cancer pharmacy in North Carolina, updates for oral chemotherapy for 2022 with Bianka Patel, PharmD, BCOP, CPP. Dr. Patel, welcome. And I do want to tell you that Bianka Patel, PharmD, BCOP, CPP is a clinical pharmacist at the UNC Medical Center. She went to pharmacy school at UNC and did her second year of pharmacy training in oncology at UNC and stayed on in a role as outpatient hematology oncology float pharmacist. Because of her role in outpatient hematology oncology, Dr. Patel has experience working in various adult oncology clinics and has the opportunity to support patients on oral chemotherapy agents. Dr. Patel, we are so glad to have you here today. What's one thing we should know about you outside of your professional background?
Thank you, Tim. One thing is that I love traveling, and as many of us, we have all put our plans on hold for the past couple of years. So really excited to hopefully get some travel plans in this summer, and looking forward to, an enjoyable summer.
Great. Well, we hope you have wonderful travels this summer. I mentioned poll everywhere before. So here we always try to make this first question kind of a softball. Oral chemotherapy is defined as any drug that can be taken orally that is used to treat cancer. So again, these are anonymous. If you think it's true, put A, or false, B, and we'll look at those in a moment. While you're going ahead and filling out that first poll, I'll say that this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Bianka Patel, PharmD, BCOP, CPP has no relevant financial relationships with ineligible companies as defined by the ACCME. All right, Dr. Patel, let's take a look. We've got quite a few people that have already answered this, and it looks like we're 79% true, 21% false. How are they doing? Up and just shifted a little bit. How are they doing?
That's perfect. So this is exactly right. Oral chemotherapy can be defined as a drug that can be taken orally that's used to treat cancer, and we'll talk all about it throughout the presentation.
Great, and thank you all for participating in that. And without further ado, navigating oral chemotherapy with Dr. Patel, and I'll turn it over to you.
Perfect. So as we mentioned, we will be talking all about oral chemotherapy during this presentation. So by the end of this lecture, I hope that you are able to identify important considerations for prescribing oral chemotherapy, explain the steps involved in dispensing and distribution of oral chemotherapy to patients. So basically, how does the drug actually get to the patient? And describe some best practices in monitoring, toxicity management, and follow-up for patients receiving oral chemotherapy. So we'll start just by talking about what is oral chemotherapy. So as you all are already aware, oral chemo is defined as any drug that can be taken orally that is used to treat cancer. It is a broad term that we are using and that I will be using in this lecture that consists of not just cytotoxic chemotherapy. So when we think chemo, sometimes we think of our traditional cytotoxic IV agents. So oral chemotherapies can be very similar to those drugs, but there's also several different types of oral chemotherapy, different classes based off of their mechanism of action. And over the past several years, we've seen a huge expansion in the development of oral anti-cancer drugs. So this includes cytotoxics, but also small molecule inhibitors that are directed at cell surface receptors and other proteins and other agents that are targeted at the tumor microenvironment. So basically, when I say oral chemotherapy, I'm including all of these drugs, basically any pill used to treat cancer. Spending on oral chemo continues to increase, so this is definitely an important topic. And really what we'll focus on during this lecture is that these drugs have several unique considerations that make them different from IV chemotherapy, and just, they have their own unique set of challenges. And so by the end of this, I hope that we're all able to navigate these challenges a little bit better. So when we think of oral chemo, there is a huge amount of benefit for patients and providers, and definitely the perception of oral chemotherapy is that it's extremely convenient. And so oftentimes our patients really appreciate being able to take their cancer medication from home. They don't have to come to clinic as often. There is some opportunity, at least, for cost savings in the form of, less infusion visits or staffing for infusion needs. There's a potential for improved quality of life. This goes hand in hand with just convenience and hopefully fewer clinic visits, and of course, less invasive. I will say, though, that a lot of these can be misconceptions, or they're just a little bit generalized. And so throughout the presentation, we'll talk about how some of these may or may not always be true. Before I go much further, I want to just orient you all to how important this topic is and why oral chemo can be such a big deal. So oral chemotherapy has really changed the treatment landscape of several different types of cancers. And I just wanted to highlight one key example here. So imatinib, which is a selective inhibitor of BCR-ABL tyrosine kinase, has completely changed the landscape of CML. And so you can see on the right here, this is a landmark trial that was published in 2003 that compared oral agent imatinib to traditional cytotoxic low-dose cytarabine and interferon. And you can see on that figure, the major cytogenetic response was about 2.5 times with imatinib. And so a huge benefit of imatinib, and this completely changed the treatment landscape for CML. So it's just one example, but to highlight that is, a reason why there's been such a huge expansion of oral chemo. So let's talk about some misconceptions. We talked about how there's definitely the perception that these drugs can be easier and safer, but this is not always true. We'll talk about how these drugs just have different safety profiles and different side effect profiles than some IV agents. They have different monitoring requirements, but it's not necessarily true that they are safer or require less monitoring. It's also not necessarily true that they have fewer side effects or easier overall. They can certainly be more convenient in some situations, but of course there's an added complexity of just medication access and getting the drug to the patient. Of course, these are drugs that are usually dosed daily at home, so it does allow for prolonged exposure from a pharmacology perspective. And another nice thing is they can be easily stopped. We can start and hold these drugs and often see resolution of side effects, so that is a matter of convenience as well. But they do have variable bioavailability, as many oral drugs do. And very important to note that they're impacted by adherence. So something that patients are relied to take every single day can certainly be impacted by adherence, and we'll talk more about that too. So as we go through this presentation, I wanted to orient you guys to this patient case. So patient CL is a 53-year-old male with relapsed mantle cell lymphoma. He was originally diagnosed in 2015 with low-risk MCL. He received his chemotherapy, he's post-autologous stem cell transplant, and he's now relapsed. He has a history of hypertension, DVT, acid reflux, and seasonal allergies. And he's retired now, but a previous lab technician. You can see on the right there, his labs are fairly stable. Potential elevation is in his creatinine, and then his medication list. So you can see there he's on an acid reducer, he's on a blood thinner, and he's also on some supplements. And so the team is considering starting oral chemotherapy agent acalabrutinib, which is a BTK inhibitor. And so we will talk about CL as we go throughout this presentation. So which of the following is true regarding considerations for prescribing acalabrutinib and oral chemotherapy for CL? And this is, we have some options here when keeping CL in mind. It is important to educate CL and any caregivers on the new therapy. It is not necessary to complete a medication reconciliation prior to prescribing the drug. Oral chemo rarely has drug interactions with other chronic medications, and baseline monitoring or labs are usually not required for oral chemo. So we'll give you all a few seconds to answer this question.
Dr. Patel, it looks like they're settling in unanimously on A. How are they doing?
That's perfect. That is exactly right. So it is extremely important to educate CL, and we'll talk about that as well. We'll talk about why the other three answers are not necessarily correct, because it is important to do a full medication reconciliation. It is very possible for him to have drug interactions, and baseline monitoring and labs are very much required. Okay, so we will kind of, as we've talked about the background of oral chemo and what it is. Now let's go into the actual oral chemo process. So step by step, how does it work? And we'll start by talking about patient selection. And this is just something to keep in mind as we are prescribing oral chemotherapy, that we do have to keep the whole patient in mind to ensure that they are an appropriate candidate for oral chemo. So some things to consider are socioeconomic issues, cost, affordability. We have to make sure that we have a plan in place to make sure that they can afford their therapy, and what we'll do if they can't. Psychosocial issues, mainly cognitive function and mental status, because we are relying on the patient at this point to take their medicine day to day. Regulatory needs can be an issue, so things like formulary, insurance approval, FDA approval, so whether the drug use is on label or off label. Patient factors, so do they have caregiver support? Are they really prepared to take care of themselves, take care of their adherence, and reach out if they have side effects and things like that? And then, of course, just how complex the treatment is. Is it something that's one part of it is IV, and then there's 2 oral drugs and that are given on different schedules? And if so, maybe that's too complex for some patients. And so all of these things are just things to keep in mind as we're making sure that the treatment is appropriate for our patient. Next, we'll spend a good chunk of time on drug dose and selection, and that is because this just one step actually consists of so many other steps. And so I think this is really the bulk of it, is making sure that the drug is appropriate, the dose is appropriate. Of course, I'm not focused on any one clinical disease state for the purposes of this presentation, but even just beyond whether it's appropriate clinically, there's a lot of other things that go into drug selection. So we'll start with talking about drug interactions. So how do we screen for drug interactions? The first step is complete a full medication reconciliation. This includes over-the-counter medications and supplements. These drugs can often have drug interactions, and so the most important thing for many of our patients that are taking several other medications is to just get a good sense of exactly what they're taking. The next step is to actually check for drug interactions. We can use drug interaction databases, prescribing information, or package inserts, and other resources, and we'll talk about that. And of course, if you have the opportunity to consult a pharmacist, that is definitely helpful as well. And then the last step is to adjust if needed. And we'll talk about some practical examples of this, but it's very common to have to make some adjustments when you're starting some oral chemotherapy. It might be that you just instruct a patient to avoid certain medications, or it might be that you make some adjustments, or it might be that you have such a significant drug interaction that you have to change your entire course of therapy. And all of those are very reasonable possibilities. The potential for drug interactions increases as the number of medications a patient takes increases, as you would expect. And remember that oral chemotherapy agents often have a narrow therapeutic index, meaning the window at which they are safe and efficacious is fairly small. And if they take too much, or if there's a drug interaction, then that could be unsafe for our patients. The most common types of drug interactions are with oral drugs that involve pharmacokinetic interactions. So basically one drug is affecting the absorption, distribution, metabolism, or elimination of another drug. And most of the drug interactions we see in clinical practice involve the cytochrome P450 enzyme system, so hepatic enzymes that metabolize drugs. So just some practical examples of drug-drug interactions. When I think about drug interactions, it makes sense to kind of lump them into three big categories. First is actually increased action of drugs. So drugs that will make the patient actually have an increased exposure to their chemotherapy. So one big example of that is venetoclax, which is an oral BCL2 inhibitor used for leukemia, with posaconazole, which is an antifungal medicine that often is given to leukemia patients to prevent fungal infections. Posaconazole is an inhibitor, a CYP3A4 inhibitor, so it increases venetoclax. So there's actually a very clear dose adjustment outlined in the package insert, but the risk here is increased exposure of venetoclax and therefore increased side effects. The next category is decreased action of drugs. So the chemo is not going to work as well. And I have two kind of key examples of this, again, just to orient you to the types of interactions that we see. So we have tamoxifen, which is a hormonal therapy for breast cancer, and fluoxetine, which is an SSRI that is a CYP2D6 inhibitor. Tamoxifen actually is activated to its active metabolite or metabolized to its active metabolite through CYP2D6. So if you give it concurrently with a CYP2D6 inhibitor, it will actually not work as well. And so this is a key drug interaction. Enzalutamide is a CYP3A4 substrate. It's a very common prostate cancer therapy. When you give it concurrently with something like carbamazepine, which is a CYP3A4 inducer, this will actually induce or increase the metabolism of enzalutamide, and it will not work as well. Then we have our third bucket, causing adverse effects, so increase or additive toxicity. Acalabrutinib, our oral BTK inhibitor, and rivaroxaban, or any other blood thinner, both have the warning of increased risk of bleeding. So there could be a risk there, and we would need to monitor patients for bleeding. Another example, nilotinib, which is an oral TKI for CML, and haloperidol, an antipsychotic, both carry the risk of QTc prolongation. So that is another example of a additive toxicity, and we would need to monitor QTc for that patient. This is just a chart here of various drug-drug interactions and common things to watch out for. It is not comprehensive by any means, just things that we see commonly. So I wanted to just point you all to the attention that there's several common drugs here, like direct oral anticoagulants, DOACs, blood thinners, apixaban, rivaroxaban, acid reducers like Prilosec, Pepcid, several cardiac medications, diltiazem, amiodarone, carvedilol, statins. All of these are really, really common medications that can affect chemotherapy. Supplements are extremely important too. As I said, these often have drug interactions. So a couple that come to mind that are very common are St. John's wort or turmeric. And then over the counters, I did want to mention this because so many of our patients will take, ibuprofen or goody powder or whatever it is over the counter. In many instances, that's fine, but there are instances in which it could potentially cause an increased risk of GI bleeding or nephrotoxicity. So it's important to just keep those patients in mind as well. And then on the bottom there, I just have a list of some other common CYP3A4 inhibitors, inducers, and PGP inhibitors as a list of drugs to watch out for. Food-drug interactions are a possibility as well. So as we know, grapefruit is a common offender. We often tell our patients that are receiving oral chemotherapy to avoid grapefruit if it's applicable to them. But grapefruit can be a CYP3A4 inhibitor. Lactose is typically not an issue, but it is an inactive ingredient in many oral chemotherapies. So it could be something that kind of flags as when you're prescribing these agents. Some agents require separation from calcium or dairy products. Some agents will require a certain even level of fat in the meals, and we'll talk about that, but food can certainly affect the absorption of certain drugs. Alcohol can cause liver enzyme abnormalities, and smoking can induce certain CYP enzymes, such as CYP1A2. So all of these things can also contribute to drug interactions. So where do we go to look for these drug interactions? I have a couple resources here that could come in handy. So the first one being Memorial Sloan Kettering has an integrative medicine database. So it's basically a compilation of several herbal supplements and other types of supplements too. And it is data driven. They have, an up-to-date recommendation, and it's meant for healthcare providers and patients. So you can go in and type in turmeric, and it will give you any potential interactions or contraindications. For our oral chemotherapy agents, package inserts and prescribing information is always a great place to look, as well as study protocols if there's some particular drug interaction that they managed. Those are always helpful as well. Lexicomp or any other drug database interaction checker is helpful as a starting spot at least, and then you can always pull primary literature from there. And of course, consult your pharmacist if you have the opportunity to. Next, let's talk about administration. So how do we actually take these drugs, and what do we tell our patients? These should typically be taken whole. Most of these drugs we're instructed not to chew, cut, or crush. There are just a select few drugs out there that actually do have some instructions for patients that cannot swallow. An example of that is Vandetanib, but otherwise, typically, we don't want to increase exposure to our patients, so we ask them not to manipulate these drugs at home. We talked about food considerations. So an example there is Regorafenib or Stivarga that actually has specific calorie restrictions on how it needs to be taken. And so it needs to be taken with a low-fat meal, and there are some examples in the package insert of, what would constitute a low-fat meal. 6, mercaptopurine, avoid dairy or citrus products. And then, of course, some oral chemotherapies require a certain amount of stomach acid for absorption. And so that is when we really have to be mindful of our patients with acid reflux. So we may need to adjust or stop their PPIs or their, famotidine, Pepcid, and make sure that they're getting the best absorption for their oral chemo. One example that comes to mind is Dasatinib, which is a TKI used for leukemia, and it is very much dependent on an acidic environment for absorption. So actually for patients that are, they have very refractory reflux, and we have to keep them on their reflux therapy, there are other things we can do. Carbonated beverage or betaine, which is a substance that's made in your body or can get through diet or as a supplement. They all actually increase production of stomach acid, so you can instruct patients to, take with a glass of soda or take with betaine. And then, of course, if you have a medication that's sedating or nauseating, then often we recommend bedtime administration, as that could be helpful. So next we'll talk about actually ordering the oral chemo. And this is, I don't want to spend too much time on this. This is actually just a list of best practice, when you're actually writing a prescription, what should be included or what you should think about. But really just a couple things I want to highlight here. The dosage is extremely important. When we're writing oral chemo prescriptions, we should keep in mind that that's what the bottle is going to say. And so it's best to be as clear as possible, include the milligram dosage, and also include, is it 2 tablets or is it 4 capsules? Because that could be a source of error for our patients, and we don't want to take chances on chemo. Route of administration is always going to be oral for these usually. And then duration of therapy and number of days of treatment. This, I think, is actually really important, again, when thinking about writing the prescription. I think it's best to write actually the number of days. So if a patient needs to be on it for 5 days out of 28 days, then we should explicitly state that. If it's 3 weeks on and 1 week off, we should explicitly state that. And also, write the correct number of capsules, just so that there's no source of error or confusion there. For refills, the only thing I wanted to mention there is that there are settings in which it's appropriate to write completely without refills. In fact, it can actually be a kind of a way to ensure safety. So for example, if you have a cytotoxic oral chemo and you're wanting to see a patient's labs before you refill it because you may need to adjust the dose, then it's actually helpful to write it without any refills. That way you know that it's not going to get to a patient until you have cleared them for treatment. Next, we'll talk about adherence. And so adherence is a huge topic. And the reason why I included it up front in just drug selection or dose selection is because I think it's important to think about adherence up front. It's something that we're going to be monitoring going forward too as well. But it's something to think about just when you're selecting an oral chemo for a patient. Are you making sure that it's going to be easier for them to adhere to, and is it the right therapy for that patient? Maybe you have a patient who struggles with adherence and maybe oral chemo is not the best choice for them. But first we'll start by talking about why adherence is important. So first, I just wanted to start by bringing up the study just to show you that non-adherence is prevalent even in the treatment of cancer, even though you may not think so, and it can be a barrier to positive outcomes. There are several reasons for non-adherence, and we'll talk about those, but the care team can really help patients overcome this challenge. And so this study was a study done in an outpatient hematology clinic where they evaluated their patients for adherence using a MARS-5 adherence questionnaire. The maximum score is 25, meaning perfect adherence, and then anything less than that was considered to be non-adherent. And so what they found was only 50% of patients were considered to be perfectly adherent, and the rest had at least something. They either missed doses or they weren't taking it exactly as prescribed. And so you can see that most of these patients are pretty close to perfect, but there's definitely the spectrum of patients that, are really not taking their medicine as instructed. Another point just to highlight how important adherence can be, or back to imatinib, which is our drug that changed the landscape for CML treatment. You can see here on this figure from that same study, on the left is probability of major molecular response and the right is complete molecular response. The blue line is adherence greater than 90% and the yellow line is adherence less than or equal to 90%. And you can see here the dramatic difference in outcomes for these patients. And so sometimes it's helpful even to notify patients that adherence can make a huge difference in their cancer outcomes. We also have some data regarding adherence at UNC. So we have a study that was done several years ago in adults receiving care at UNC outpatient oncology clinics that have CML, kidney cancer, breast cancer, or some type of GI malignancy. And we were really looking to analyze patients' perception of adherence to oral chemo. And this went out with a 30-question survey that also included, questions around reasons for non-adherence. And so the reasons were confusion or misunderstanding about the timing of drug with food, forgetfulness, reducing or stopping the drug without informing the MD, whether that was for side effects or other reasons, and then difficulty understanding directions on the drug label. There are many other factors that can influence adherence and that we can kind of lump into three main buckets. Patient factors, so their mental status, their physical status, comorbidities, what actually is their perception of their disease and what their expectations are, and socioeconomic status can play a role as well. Maybe their therapy is too expensive and they're not able to afford it. Treatment factors, the goal of therapy, the complexity, what are the benefits or the risks, and do those match their perceptions? So I think that's another really important thing to educate our patients on. Are they actually going to feel better starting this treatment, or are they actually going to feel a little bit worse from the side effects of the treatment? And most important thing is to orient and set that expectation up front, because otherwise that can be a reason for non-adherence. Health system factors such as relationship with providers, access to clinics, satisfaction, and insurance coverage all can play a role as well. How can we monitor adherence? So we have things like pill diaries, pill counts, prescription refill rates, questionnaires, cell phones, alarms, things like that. I will say we don't routinely formally monitor adherence outside of a clinical study setting. However, there are definitely a lot of tips we can give our patients when we're encouraging adherence or helping them to improve adherence. And this is a really big piece of education. So we can set them up with calendars or checklists. We can educate them and their family members, people that are helping them manage their medicines. We can help them establish a routine. We can help them with pill boxes and other, other tips that can help them just remember if they're going on a vacation or something. Alarms and reminders are a huge thing in today's day and age, using some type of app. So all of these are tips that we can provide for our patients. So now that we've talked about the drug interactions and adherence piece, the last piece of this drug and dose selection is baseline monitoring and toxicity profile. And here I want to highlight that oral chemotherapy is not without its monitoring. And there's actually a lot of unique lab or monitoring requirements for many of our oral chemotherapies. And so the purpose of this is to just show you a spectrum of various drugs and various monitoring parameters that we have to keep in mind. So examples include abiraterone, which is a common prostate cancer therapy, requires very strict hepatic enzyme monitoring. Erdafitinib, which is an FGFR inhibitor for bladder cancer, require baseline eye exams and regular eye exams after that as well, because there is a risk of retinopathy. Gilteritinib is a FLT3 inhibitor for leukemia, has a risk of QTc prolongation, and so regular EKGs are recommended. Lenvatinib is a VEGF TKI, a very common drug for many of our solid malignancies, has fairly strict monitoring requirements for blood pressure, EKG, thyroid. Nilotinib is a BCR-ABL TKI for leukemia. Actually, we have to monitor amylase and lipase because of our risk of pancreatitis. Venetoclax, which we talked about earlier, has a risk of tumor lysis syndrome, so we have to make sure we're getting TLS labs. And so all that to show you that it is certainly not easier or less monitoring for many of these drugs. And we have to actually go through and figure out what monitoring a patient needs before and throughout their care on this therapy. And we just need to make sure that we're educating our patients on this too. Many therapies have both similar and unique toxicities to consider. So when we're thinking about a toxicity profile, we're used to thinking about myelosuppression, which is common for many of our oral chemotherapies. And then there's also some other unique things. So I just wanted to highlight what these three drugs that, there are some things that are very common and then some things that are more unique. So Palbocyclip, which is a cyclin-dependent kinase inhibitor for breast cancer, can be myelosuppressive, but it can cause some other, GI symptoms, mouth sores. Trifluridine, tibresol, an antimetabolite for GI malignancies, can cause myelosuppression and requires actually pretty strict CBC monitoring. Acalabrutinib is a BTK inhibitor we talked about, carries a risk of atrial fibrillation, so it's something that we have to monitor or educate our patients on as well. So all of these things are things to consider on the front end when you are prescribing an oral chemo, because this will all help make sure that this is an appropriate therapy for that particular patient. Another layer to safety is that there are a few drugs out there that have a REMS program. So a REMS program is a risk evaluation and mitigation strategy program, basically required by the FDA to make sure that the benefits of a drug outweigh the risks. So an example is lenalidomide or Revlimid, therapy for multiple myeloma. This drug is actually associated with both birth defects as well as a risk of blood clots. And so it has a patient safety program that we have to think about on the front end, because we will need to make sure that our patients are educated, they're enrolled into that REMS program, and that we as providers and the patients are following all of the requirements, whether that's using a condom or pregnancy test or whatever it may be. When it comes to choosing an agent, if you do have the option of several drugs within a therapeutic class, then it is great to be able to select based off of patient factors and comorbidities. So again, this is not comprehensive, but just a way to display the example in practice. So these drugs are all tyrosine kinase inhibitors for CML, starting with imatinib, our first generation, all the way to ponatinib, third generation. And I just wanted to highlight things that we can take into account. Say we have a patient that has poor adherence already, maybe a twice daily medication is not the best option for them. Maybe you have a patient who has a severe acid reflux already. You probably want to choose an agent, if you can, that is not pH dependent for absorption. If you have a patient that has a lot of cardiovascular comorbidities, then maybe avoiding ponatinib because of its risk of vascular events would be a good idea. So it's just, all of these things are important to keep in mind on the front end. And then this brings me to the next step in our process, which is just the benefits investigation, meaning how do we actually get the drug to the patient and how do we get it paid for and things like that. So the first step is confirming their insurance coverage. So just making sure that we have that up-to-date information. The next step would be to actually send a prescription to a specialty pharmacy, whether that's an outside pharmacy or if you have one that is associated with the healthcare system. But that is the first step. Once the specialty pharmacy runs the prescription, most of the time it is going to require what's called a prior authorization, meaning that insurance will require us to answer a few additional questions to make sure that this is appropriate and that they're willing to cover it. And this is true for pretty much all cancer therapies because they are all very expensive. Then the next step after making sure, or after we've received approval from the insurance company, the next step would be making sure that they have an appropriate copay. And so one thing to note here is that this is extremely important because most oral chemotherapies will have a high copay. It will be in the hundreds to thousands of dollars. So it's not affordable for our patients. There are things we can do. There's things like copay cards, grants, manufacturer's assistance, meaning you're applying for free drugs straight from the drug company. And all of these things are a possibility, and we need to make sure that we're thinking about it as well as letting our patients know. And then the last step is just making sure that our patients actually confirm and schedule the delivery with the specialty pharmacy over the phone. Of course, remember to educate patients on this process. I like to tell them about every step of this just because I think it allows for less confusion on their end. So if they get a letter from their insurance company that something was denied, that they don't feel like they're confused or they don't feel like, oh, that means they're not going to be able to get the medicine. And of course, set expectations for how long it can take. This process takes 1 to 2 weeks usually. And so I like to tell patients on the front end so that they don't, they don't worry if it's been a couple of weeks and they haven't gotten the medicine yet. Specialty pharmacies are, are pharmacies that dispense these medications, these oral chemo pills that are always considered specialty drugs. And there's a huge benefit to using specialty pharmacies. Most of the time, we are working with highly experienced and knowledgeable oncology pharmacy staff. They are able to provide education by phone or by mail. They deliver these medications, so the drug ends up directly to the patient's home, and that ends up being really convenient for most patients. Many of them will work very closely with insurance and copay assistance, so usually even some external specialty pharmacies will have copay assistance programs or copay assistance teams. However, there are sometimes some challenges. So usually they're not local. So every now and then you have a patient that is, really wanting to be able to physically pick up their prescription, or they're harder to reach over the phone, and that could be a challenge. For external pharmacies that are not associated with the healthcare team, sometimes they can receive education and instructions that are different from the healthcare team, which is an understandable scenario, but can cause confusion for the patients. And then, of course, patients sometimes get they can misunderstand that they have to pick up their normal chronic medications from their local CVS or Walgreens, but then wait for everything else to come to them in the mail. We talked about how these drugs have extremely high copays, so financial toxicity is definitely something to keep in mind. Out-of-pocket costs can be a huge source of distress for our patients, and there is evidence to say that cancer patients are more likely to experience financial toxicity, so it's something for us to definitely be mindful of. Here I just have some references for you all and things that are listed. These are some resources for patients that we can go to as just a starting spot for where to look for cost assistance. And on this slide, I have some other resources listed. So food, utilities, gas, counseling, peer support, transportation, childcare. These are all just places that we can start to look for if we need to support our patients. And so we'll go back to our patient case here. CL who is starting acalabrutinib or considering starting acalabrutinib, and go to our next poll question. Which of the following is true regarding the steps to dispense oral chemotherapy? Is it A, it is important to educate patients on the logistics of oral chemo? B, most oral chemo does not require prior authorization? C, most oral chemo can be picked up at a local pharmacy? Or D, most oral chemo is affordable without copay assistance? Okay, it sounds like most everyone has already chosen the option A, which is exactly right. It is important to educate patients on the logistics of obtaining oral chemo, and we talked about why the other three are not correct. And so this is a great way for me to transition into actually our next bucket here, which is patient education. And here I just want to provide some resources. This is actually a list here of just some key components when we think about best practice for how to educate patients on these drugs. Everything from the diagnosis to the drug itself to logistics, how are they going to get the drug, toxicity, side effects, storage, handling, how to dispose of the drug, monitoring, what will their long-term plan look like, how will they get refills. It's important to educate patients on all of these things. Where do we go for patient education resources? There's a few websites that we can use. I have listed a couple examples here. Both of those websites have some handouts at least translated into Spanish, so I think that's a great resource for many of our patients. The Hematology Oncology Pharmacy Association, or HOPA, actually has a database of handouts for oral chemo agents as well as some IV agents. And that is a great resource. I think their handouts are very comprehensive and very much patient-friendly. And then, of course, some institutions will develop their own handouts, and the FDA has medication guides, which are a great resource for some drugs and some patients, although sometimes it depends on the situation as they can be overwhelming. But most importantly, be mindful of patients' health literacy. Before suggesting any of these handouts, it's important to get a handle on, what a patient can comprehend. Most of these are targeted towards a lower health literacy level to accommodate all of our patients, but even still, they can be overwhelming for our patients. This is more like just a reference slide for oral chemotherapy handling. If our patients are starting a new oral chemo and they've not had it before, I do usually review these things with them to make sure they're keeping away from children, pets. If they are having a caregiver give them the medicine, that they should wear gloves. If they're using a pill box, then they should store the oral chemo in a separate pill box so it doesn't expose all of their other drugs to chemo. Many oral chemo drugs are dispensed in blister packs, so that is usually very helpful and it eliminates the need for pill boxes anyway. And then storage and disposal, again, if you have a new start patient, it's important to go through these things as well. Most oral chemotherapy should be stored at room temperature, but there are a couple of drugs every now and then that are required to be refrigerated. An example is trametinib, which is an important counseling point. For disposal, we do need to tell these patients that they should not flush these down the toilet or anything like that. These are hazardous drugs. For REMS drugs, so for example, Revlimid or lenalidomide that has that REMS safety program associated with it, it's actually required that we mail that any leftover pills directly back to the manufacturer. But otherwise, we should just provide instructions for hazardous drug disposal. And I have another reference slide for you all on drug disposal in North Carolina. So the National Association of Boards of Pharmacy has a drug disposal center locator. If you go to this link and type in your zip code, then it pulls up various local pharmacies that will accept waste, and it will tell you if it accepts chemo waste. So that is definitely an option for us. UNC Central Outpatient Pharmacy will take our chemo waste, and also some local police departments will. It is very important when talking about education to not gloss over reproductive safety, especially for our younger patients and patients that are of childbearing age. We absolutely need to address pregnancy, sexual activity, contraception. There are some oral chemos that require non-hormonal contraception because the chemo itself can interact with hormonal contraception. So examples of this are belzutifan or dabrafenib, and we need to keep this in mind on the front end when we're starting this type of therapy. Okay, and this brings me to the very last step of the oral chemotherapy process, which is monitoring. And we already talked about baseline monitoring in labs and toxicity profiles, but this is kind of an example follow-up for a patient starting oral chemo. So this is more often than not what we'll do at UNC for many of our patients on oral chemotherapy. We'll count day 1 as the start of oral chemotherapy. And then on day 8 or day 15, so 1 to 2 weeks later, they'll often have a virtual visit with our pharmacists. This at your institution, if it's not a pharmacist, it could certainly be a telephone call with a nurse, or in APP, it could be anyone from the team. But I think it is important to have that touch point within 1 to 2 weeks of starting oral chemotherapy. At this visit, we can talk about medication reconciliation, adherence, tolerance, so making sure that we're getting an understanding of side effects, and then other monitoring. And then 3 or 4 weeks later, we'll bring them back to clinic for labs and a provider visit. For that day 8 or day 15 visit, one of the biggest things we're doing is symptom management. And so again, this is just an example management strategy for patients that are starting VEGF TKIs. So for example, when I have a patient that starts Lenvima, for that day 8 or day 15 visit, I'm going to make sure that I'm checking on their blood pressure, that they've been logging their blood pressure, making adjustments if needed, making sure that they're moisturizing their hands and feet to prevent any hand and foot skin reaction, other supportive care, making sure they have their nausea medicines, diarrhea medicines, and other supportive care. And this brings us to our last poll question. Which of the following is true regarding monitoring and follow-up for patients starting oral chemo? Is it A, oral chemo does not require other supportive care medications? B, most oral chemo does not require regular lab monitoring? C, patients receiving oral chemo are unlikely to require frequent symptom monitoring? Or D, adherence should be monitored for patients on oral chemotherapy? Well, it sounds like we have a unanimous agreement on D as well. I agree with that. That's absolutely right. Adherence should be monitored regularly. It should be something that we're regularly asking our patients if they're missing any doses. And we talked about why the first 3 are not necessarily correct. We do need supportive care, lab monitoring, and symptom monitoring. And then I'll leave you with just the last piece here, the role of the pharmacist. So pharmacists can be extremely helpful in in the setting of oral chemotherapy, just helping patients and providers navigate the challenges of oral chemo. And we talked about counseling or medication access, screening for interactions, encouraging adherence, lab monitoring, or toxicity management. And again, this is just our last slide here where I wanted to just highlight putting it all together in practice. This is an example workflow of everything, starting with visit with the oncologist, diagnosis is made, patient will, or the patient will get the prescription for the oral chemo sent to a pharmacy, the pharmacist will educate them, and then we will go step by step with everything we talked about with a mid-cycle check-in with the pharmacist, and then ending with your follow-up visit with the oncologist. So to summarize, there are several important considerations for oral chemo. Dispensing and distribution of oral chemo can certainly be a complex process. Baseline and lab monitoring is key to ensure patient safety, and toxicity and symptom management is also key in helping patients stay on their therapy and tolerate therapy. These patients require close follow-up, and pharmacists, nurses, advanced practice providers, everyone can play a huge role in helping manage oral chemotherapy. And I can take any questions.
All right, Dr. Patel, this has been fascinating, and what a clear presentation. This has been great. While we're waiting for questions to come in, I know I've got a couple. You mentioned some of we're always interested in technology and gadgets here at Cancer Network, and you had mentioned some of the automated pill administration tools. I know there's a lot out there, things like ePill Station and Hero and ePill MedTime Pro and all sorts of other things. What's your sense of kind of the return on investment of those, given the importance of adherence? Are these things worth the cost, and can they be beneficial for patients?
Thank you, Tim. That's a great question. I'll be honest, we don't use these in practice, so I am less familiar with the ins and outs of these drugs or these devices, but I will say adherence is extremely, extremely important, and we probably have expanding data that's actually showing the importance of adherence when it comes to outcomes. I think when we have more of that data for more malignancies, then it might be more worth it to be spending a lot of money on tools that can improve adherence. So we're getting there, but I think at this time, I'm not sure that the cost is always worth it for a couple extra doses, if that makes sense.
Gotcha. That sure does. Thank you. And again, while we're waiting, I'm thinking again about adherence, and some of our previous guests who've talked about patient-reported outcomes. Specifically, I'm thinking of Dr. Bosch. Has there been research done in terms of looking at adherence and the role that may have with patient-reported outcomes and being able to monitor side effects and comments through the patients, and that playing a positive role in adherence?
Yeah, there has been. That's a really great question, and I just didn't have time. Otherwise, patient-reported outcomes is such a great topic to add to this oral chemotherapy. But there is data to display the importance and the benefit of patient-reported outcomes. So basically, asking our patients directly to report things like nausea or fatigue or other side effects, and being able to intervene on that. There is data to show how important that is. And there is some data that also shows that can improve adherence in various types of malignancies. And we actually have a study that is actually led by Dr. Rose and Katie Morgan from our GU clinic that is actually evaluating exactly that in our renal cell carcinoma patients, looking at if patient-reported outcomes can improve adherence and dose intensity for patients on VEGF TKIs.
Great. Well, that's good to hear, and we'll we'll follow up with some questions when we have upcoming patient-reported outcome presentations. So as well. There's a question. No new ones on poll. Oh, we just had one come in on poll everywhere. And then we actually had one in the chat too. Someone had said, thank you for the insightful talk. Could you share briefly on the practice of deprescribing of small molecule oral chemotherapy, for example, imatinib in treatment of CML?
Sure. So I think that question means just generally deprescribing TKIs in CML. That is a great clinical question. I will say there's some guidelines and data out there for TKI discontinuation. It's not a practice at UNC that we routinely adopt, and so it totally depends on the patient and the circumstance, but we do typically follow the guidelines and data that's out there when thinking about TKI discontinuation.
Great, thank you. And we did have a comment, someone that said, fantastic presentation. I wholeheartedly agree. Addressing the multiple challenges providers and practices face with oral chemotherapy ordering and administration. So glad to hear that comment, Dr. Patel. Of course, this presentation will be recorded and it will be available as an enduring material for the next year for anyone who would like to go back and either rewatch or watch for the first time. So please feel free to share this with others. One last one. We'll take this one here. So thank you for the insightful talk. Could you share briefly on the practice of oops, you know what? That one had come. That's the one we just took. So we'll go ahead and move on. And we want to say thank you. Thank you to the people of North Carolina for your generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank this team. This team is amazing, and this is one of many, many lectures that this team at the UNC Lineberger Cancer Network, all of them play a very important role in making this success. So Mary King, John Powell, Jason Paler, Veneranda Obore, Oliver Marth, and Andrew Dodson. Thank you to all of you for your role in making this happen.